Osteotomy, metacarpal, each. Phalanx of finger, each. The physician incises the skin and dissects to the bone. The bone is incised and removed. The incision is sutured in layers. Osteotomy and transfer of greater trochanter of femur. Incision over the greater trochanter and detaches the greater trochanter with a Gigli saw or osteotome. The physician may reposition the trochanter, and repositioning increases the abductor lever arm and / or tightens the abductor musculature. The physician drills holes to secure the trochanter to the femur with wire. The incision is repaired in layers. Osteotomy, iliac, acetabular or innominate bone. With open reduction of hip. With femoral osteotomy. With femoral osteotomy and with open reduction of hip. The physician makes an osteotomy cut on the innominate bone using a Gigli saw. The osteotomy extends from the sciatic notch to the antero-inferior spine. The physician may harvest a separately reportable full-thickness bone graft from the anterior part of the iliac crest and close the surgically created graft donor site. The graft is trimmed to the shape of the wedge and inserted into the osteotomy. A Kirschner wire is drilled through the ilium, bone graft, and into the lower fragment. Another wire is placed parallel to the first. Joint stability is re-evaluated. Any released muscles are reattached. The femoral head is reduced again into the acetabulum. Any released muscles are reattached. The capsule is closed with sutures, giving added stability to the reduction. The incision is repaired in layers. A single spica cast is applied. For femoral osteotomy, a lateral incision is made from the greater trochanter, extending down the leg 8 cm to 12 cm. Dissection exposes the lateral femur. Transverse and longitudinal orientation lines are made on the femoral cortex with an osteotome. The physician makes an osteotomy cut at the transverse line in a transverse or oblique direction. Another cut is made at an angle so that a wedge of bone can be removed to complete the correction. The rectus femoris is reattached to its insertion point. The hip is reduced as well. A side plate is secured to the femur with bone screws. The incision is repaired in layers. A 1 1/2 spica cast is applied for 8 to 12 weeks. Osteotomy, pelvis, bilateral, e.g., congenital malformation. The patient is placed in a supine position. The physician releases the adductor muscles by subcutaneous tenotomy. The physician makes a small incision over the origin of the adductor muscles. Dissection is carried down to the adductor tendon. The physician uses a small blade to release, free by incision, the tendon. The physician makes an incision from the middle of the iliac crest to the middle of the inguinal ligament. The head of the rectus femoris muscle is released. Dissection exposes the hip joint capsule, which is incised in a T-shaped fashion. The periosteum is stripped from the medial surface of the ilium to the sciatic notch. The ilium is divided or cut with a Gigli saw in a straight line from the sciatic notch to the antero-inferior spine. A full-thickness bone graft is removed from the iliac crest and trimmed to the shape of a wedge. The physician closes the surgically created graft donor site. This allows the acetabulum together with the pubis and ischium to be rotated as a unit. The bone graft is inserted into the osteotomy. 2 Kirschner wires are drilled parallel to each other through the ilium and bone graft for fixation. The femoral head is reduced into the acetabulum. The capsule is repaired and tightened with sutures to add stability to the joint. The incision is repaired in layers. The same procedure is performed on the other side. Both hips are placed in spica casts.